Hello, this is Dr. Ed Kim. This is part 3 of our guide on how to teach for residents. And in this podcast, we're going to talk about inpatient service rounds. The goals and objectives will be to help you integrate the principles of RIME model for inpatient rounds and to help you use the trajectory model for post-op recovery as the starting point. I want to remind you how important patient presentations are for learners, both in terms of you understanding how they're thinking and it allowing us to reveal their gaps in their fund of knowledge as well as problems with application of knowledge. And this interaction is where we have the opportunities for providing good feedback and to monitor their progress in their acquisition of clinical skills. As we already know, the RIME framework is the one that we commonly use here at UCSF, where the learner goes from being a reporter, just gathering data, to interpreter, synthesizing, prioritizing, understanding the significance of specific data, to manager, where we discuss concerns regarding treatment and articulate pros and cons of each options of treatment, and finally to educator. We saw that for the new patient history and physical, there are a couple simple ways to help our learners go from being reporter to interpreter. The first point of focus is the identification of chief complaint, the one-liner. And basically, there are two things that we can encourage our learners to help them become better at interpreting. First is to include only the most relevant past medical history in this one-liner, meaning think about what in the past medical history or comorbidities that would affect their treatment or are heavily important in considering their diagnosis. And secondly, to decide whether the patient's diagnosis is already established or not, and to start out with the diagnosis itself if it is established, or to start out with just symptoms and signs if the case itself is going to be more of a diagnostic conundrum. And secondly, the focus is really on the history of present illness, that it is important to put all the information necessary to create a coherent narrative. And this means including specific details from exams, labs, and even studies into the history of present illness. And what this process does is it allows it allows the learners to start prioritizing and recognizing, or at least trying to recognize, the relevance of the data in context and only put those that are important in the history of present illness. So the idea is to try to develop something similar for the inpatient presentation, which is usually in the SOAP format. And the SOAP format starts out with the one-liner and is followed by the subjective, objective, and assessment and plan. Are there simple steps that we can help our learners do to help them become an interpreter, and how would we recognize it, and what are the practical feedbacks that we can provide? And it turns out the trajectory model of postoperative recovery, which we also discuss in more detail in a separate podcast, is a great way to help ground our learners in doing this. And basically, this model is one that states that operations all have an expected course of recovery. Every operation has a typical length of stay or average length of stay, milestones in recovery, as well as complications that are common and most feared. So for example, for a laparoscopic colectomy, you expect usually 5 days in the hospital. The main things that people need to do before they can leave, or the progression of patients, is to be able to eat, have bowel function, and to have good pain control and ambulate. And the complications that we're usually concerned about are anastomotic leaks being the most feared complication, and wound infection being the most common complication. And then the other key point is that this expected course of recovery can be modified based on individual patient factors. So first of all, what are the preoperative health status, meaning how sick is the patient before the operation? Is this an otherwise healthy 55-year-old man, or is this a 75-year-old gentleman with coronary artery disease, CHF, and COPD? The latter, who's much sicker, would more likely to have a longer and potentially a rockier post-op course. The other part is, how invasive was the operation? Is this a small cancer that was easily taken out, or was this a big cancer that required perhaps even a conversion to an open operation, or that the patient had prior operation and required significant lysis of adhesions? So depending on how long the operation was, how much blood loss there was, how involved the operation was, obviously will also adjust or modify what would be the expected course of recovery. This expected course of recovery is a great framework for helping a learner understand and interpret the postoperative recovery process. And so what we can have them do is, first of all, since there isn't a rush as in the case of the clinic, help them take some time and with your guidance, help them define what the anticipated trajectory for this type of operation is, or whatever type of operation that they're following. And then encourage them to interpret all the findings, both in terms of patient subjective complaints as well as lab values and studies, in light of what is expected, what is probable, and what is possible within the framework of postoperative recovery. And then have them also every day assess the overall status of the patient compared with the anticipated trajectory. Are they on trajectory or off trajectory, and why? And basically what we're doing is we're helping them see the big picture. Oftentimes people get so focused, especially novices, on the details, they lose sight of the big picture. And some of the big picture questions that are really obvious if you think about it, and also allows you to utilize and utilize your prior fund of knowledge, are simple questions to ask. How sick was the patient before the operation? It's very obvious. If they were very sick, they're going to be sicker after the operation. How complicated was the surgery, as we discussed before? The same type of operation can be very different in terms of how complex and what type of post-op recovery we can expect from them. And what recovery do we anticipate? What are the most feared complications? What are the most common complications? So complications after vascular operations are going to be completely different from a bowel operation, and we're going to be looking for different things. The pulse exam is much, much more important after a bypass in the leg rather than, somebody who had a gastric resection. What are the most common complications, meaning things that you're more likely to see? Wound infections, urinary tract infections. These are things that we're going to want to watch out for. And then what are the comorbidities and their related complications after an operation, because these are going to be things that we're going to look for. And the picture on the right is a kind of a simplistic example of trying to get people to understand the obvious, meaning that when you have a gastrointestinal operation with an anastomosis, there's always a risk for leak. And we're always watching out, or at least being aware of the possibility that a patient can have a leak after an operation with an anastomosis, versus when somebody has an ileostomy or a colostomy. That's not as much of an issue, and we can be much less concerned with regard to an intra-abdominal catastrophe related to this type of process. That sounds very obvious from a big picture standpoint, but when you're lost in the woods, we've often found that people don't necessarily understand or have grasped the significance of this. So let's move on to the specifics. So inpatient presentation format, the first is the first liner, the identification of the patient and the chief complaint, which usually is about the operation and what the operation was and what post-op day it is. I would say for an interpreter, the one-liner should be a little bit more detailed. I would say not just what the operation was, what the indication for the operation was, or an admission if the patient is a pre-op admission or a post-op readmission, and then reason for the specific operation if it was chosen and there are other options. So if we take the vascular surgery example again, if there was a choice between a bypass versus a stent placement, if that could be explained, that would be an excellent way to demonstrate an interpretation of or a higher level of thinking. And here you can also include the most relevant past medical or past surgical history that might affect the post-op recovery, such as severe COPD or CHF. And this is where major concerns both related to the operation or the comorbidity can be expressed, but this could also be done at the end in the assessment part as well. And that goes also for the post-op course so far. So let's look at an example of this. So on the left is a simple reporting of a 72-year-old man whose post-op day from a right hepatectomy. On the right is an interpretation where you talk about who he is, but you also talk about, look at the second line, what the indication for the operation was. It was for hepatocellular carcinoma. And third line is even more important, or the third bullet is even more illustrative interpretation, in that the person is explicitly stating what the major comorbidity of the patient is and what the main concern in the post-operative recovery is. This is a cirrhotic patient who's now having a liver resection, so post-op liver failure or liver decompensation is a clear concern, and and this is being clearly addressed. The next two sections, the subjective and objective, are a little simpler, and but these also can be presented in a more interpretive fashion, or at least thought of in a more interpretive fashion, and that is for the learners and for us to encourage them to think about what's relevant, what's worth mentioning, and among these are the milestones for recovery for each of the specific operation. So as for bowel surgery, it's usually pain, bowel function, and activity. And always trying to connect any events that occur or complaints to the operation and what we would and the potential complications that we are anticipating or we are being very vigilant about watching for. So next, let's talk about the assessment and plan. The assessment and plan for the interpreter should include, obviously, repeating the one-liner, and then this is where your learner should, put their nickel down and state whether the patient is on expected trajectory or not. This could obviously qualified, meaning they're definitely on trajectory, or they're a little bit off trajectory, or they're concerning for being off trajectory, and then address the milestones for the recovery. The ambulation status, their bowel function status, their pain, and address concerns explicitly, even if they haven't occurred. That's what I mean by pertinent negative. Somebody has bad COPD and their pulmonary status is fine. I think it's important to say their pulmonary status is okay, despite the fact that this patient has a pre-existing severe COPD. So it may take a little bit more time, but I think even in workarounds, it might take an extra minute. But I think it's important for us to encourage our learners, and this is also can be done obviously maybe in the evening rounds if you are really rushed in the morning, that they are allowed to give a little bit more detailed presentation, especially at the front and the end of their inpatient rounds. So on the left for the assessment plan is a 68-year-old man, post-op date from X-Lab, lysis of adhesions and small bowel resection for SBO. Oftentimes from there they go right on to the plan for today is et cetera, et cetera, et cetera. Whereas on the right is the same thing regarding the identification of the patient, but there's a statement or there's an assessment or interpretation of whether the patient is off trajectory. And in this case, if this person does not have bowel function yet and still has an NG tube, so they are off trajectory because you'd expect return of bowel functions a little bit earlier. So that is an interpretation that the learner has to make. And then you can go on to the plan, and with each plan, you can explain concerns if there are concerns. And then on the last bullet, and this is not obviously a complete assessment and plan for this patient, but in the last bullet, there's the learner addresses concerns regarding complications. That one of the complications that we're always concerned about are wound infections, and that there's no evidence of a wound infection so far. Another example would be if this was a dirty case and the wound was closed. I think every day it would be important for them to for the learner to address the concern for wound infection and the fact that there is no that the wound either has early signs of infection or doesn't. Anyways, so in summary, our goal is to develop our learners to be good reporters, then good interpreters, and then going on to being managers. Inpatient care is a major part of their experience, and patient presentations and progress notes are the media through which we can teach and assess clinical skills development. So this is where we can provide them feedback and help them become better at interpreting and understanding their patients and the patients that they are following. And using the trajectory model to ground their learning is an excellent way to do this. Thank you very much for listening.